Many patients come to our OPD with recurrent pregnancy loss. Recurrent pregnancy loss, or there is a habitual abortion. That means the abortion is occurring again and again, one times, two times, three times, and so on and so forth. The first question in the mind of wife and the husband is, "Sir, why did this happen to us? What is the cause? Did I do something wrong in my pregnancy that this is happening? Why it is happening to me only?" Recurrent pregnancy loss is an emotionally very traumatic condition. Recurrent pregnancy loss patients are absolutely depressed. They do not see the light at the end of the tunnel. It is a very, very important topic. We'll discuss today about recurrent pregnancy loss, what are the causes of recurrent pregnancy loss, how to diagnose the cause of recurrent pregnancy loss, what test we do to diagnose the recurrent pregnancy loss. Can the recurrent pregnancy loss be treated? Can it be prevented? Can a patient or a female with history of recurrent pregnancy loss ever deliver a child? We'll discuss all these things. Good morning, I'm Dr. Rajat and you have started watching our YouTube channel, The Fertility Gynecologist. The likelihood of a recurrent pregnancy loss is about 1% of all the pregnancies. Now, first and important thing is whenever a patient comes to my OPD, she says that, "Sir, I have 2 abortions or 4 abortions." I first of all inquire 2 things. Whether those abortions were documented on ultrasound, whether those abortions were just plain delayed menses was there, or whether those abortions were based on only UPT positive was there and then the bleeding occurred. There is a definite differences between all these things. If it is a plain delayed menses, patient thinks that she may be pregnant when she may not be pregnant. When there is only pregnancy on urinary pregnancy test, but it is not documented on ultrasound, and then the patient has bleeding, it is more in the category of biochemical or a chemical pregnancy. I have made a video, please go and have a look at it. Most important thing for us is, as a gynecologist, is to know the cause of pregnancy loss, at what stage the pregnancy loss occurred. Was it a blighted ovum when there is only gestational sac which is there but with no yolk sac, no fetal pole, or fetal cardiac activity came and then went away, or fetal cardiac activity did not come? All these things, they tell us about the absolute important weeks of pregnancy, which is important in me in diagnosing the further cause of pregnancy. See, for example, if there is a blighted ovum, then it will tell to me that there is a definite deficiency of folic acid and vitamin B12. And in most of the cases, if I cover that deficiency with vitamin B12, either in injectable or in oral or in sublingual forms, the likelihood of recurring that pregnancy loss is decreased. If fetal cardiac activity came and then went away at 6 weeks, then it suggests to me that there is some kind of a thrombophilia problem. Either it can be acquired or it can be hereditary. In many cases, the reports may not suggest anything, but sometimes, like I'll discuss in the video later on and in other videos, unexplained infertility, unexplained loss of pregnancy, in many times is because of an antiphospholipid syndrome. The most important cause of recurrent pregnancy loss is the age of the patient. As the age of a female increases, the chances of chromosomally abnormal babies, specifically aneuploidy, increases. I'll post a chart in this which says that in the less than 35 years, the aneuploidy is less than 10%. But the moment that age goes to about 40 years, the aneuploidy becomes 50%. That means 1 in every 2 pregnancies is an aneuploidy. And if it is more than 45% years of age, almost every pregnancy is aneuploid. I'll give an analogy to this. If you go to a movie hall and eat a popcorn tub, the popcorns which we eat, initially they all are of good quality, but the moment we go down, the popcorns, some are good, some are bad, and the last popcorns mostly all are bad. So that is what it occurs at the increasing age. As the age increases, the quality of egg deteriorates, the chromosomal problems increase, and there is more chance of an aneuploidy. And as such, in about 70% cases of pregnancy loss, there is no cause which we can find. Those are unexplained pregnancy losses. Out of those 70% cases, almost 90% are aneuploidy. Again, I am making a very important statement. In most of the cases of pregnancy loss, mostly the cause cannot be found, and mostly they are aneuploidy pregnancy loss. We'll discuss aneuploidy later on in the video. Let's come to the causes of pregnancy loss. The causes of pregnancy loss can lie in the uterus, they can lie in the cervix. In uterus, there can be a polyp, there can be a fibroid, it can be an adenomyosis, it can be an Asherman syndrome. We'll make a different video. It can be a septum of a uterus, it can be a double uterus, it can be a unicornuate uterus. All these, they lead to the abortion. Whether the anatomical causes of uterus need to be corrected, whether the polyp needs to be corrected, whether the fibroids need to be removed, what can be done for adenomyosis which have a pregnancy, which cause pregnancy loss. Do we need to make the double uterine cavity single, or do we need to do the lateralization of cavity, lateralization incision to be kept in a narrow uterine cavity? Do we need to clear Asherman syndrome? I have made a separate video on most of the topics. Second comes cervix, short cervix. If there is a short cervix, then it causes recurrent mid-trimester pregnancy loss at about 13, 14, 15, 16 weeks. There is a early labor, preterm labor. Again, I have made a different video on preterm labor. I have made a video on cervical encerclage, when to do cervical encerclage, whether McDonald's cervical encerclage would do, when to do a laparoscopic cervical encerclage, when to do an abdominal cerclage. Are the indications definitely favoring the need of a cervical encerclage, or the progesterone injections or tablet would do? I have made a separate video on that. There can be an endocrine causes, thyroid. Now, if thyroid is well controlled, then it does not lead to abortion. But if thyroid is not well controlled, or there is an association of thyroid antibodies, anti-TPO antibodies, anti-TG antibodies, that definitely predisposes to the increased chances of abortion in a female. Diabetes, again, if it is well controlled, it may not lead to abortion, but if it is uncontrolled, it will definitely lead to miscarriage. And that is why for every patient of a recurrent pregnancy loss, we get an HbA1c done, and HbA1c before planning of pregnancy has to be less than 5.5. It is very, very, very important. Polycystic ovarian disease patients have got multiple problems, and they are associated with increased chances of recurrent pregnancy loss. There can be an increase in testosterone level, there can be increase in prolactin level, there can be increase in the insulin resistance level, there can be multiple problems. So polycystic ovarian disease also need to be controlled before planning of pregnancy. Like I said, hyperprolactinemia also needs to be ruled out in the endocrine causes. And the most important cause is blood clotting disorders. Blood clotting disorders are called thrombophilia in our medical terminology. They can be hereditary thrombophilia, or they can be acquired. Acquired thrombophilia are mostly because of the autoimmune disorders. They are mostly because of anti-phospholipid syndrome. Phospholipids are basically there in the cell membranes of most of the cells. And what these anti-phospholipids do, they have a massive interactions with cytotrophoblast, the functioning of cytotrophoblast. They lead to the increase in maternal inflammatory response. They decrease the chances of implantation. They cause massive, massive problems. Anti-phospholipids are a group of 16 to 17 antibodies. We have clinically got only 4 antibodies which we can diagnose in a better way: lupus anticoagulant, anti-cardiolipin antibody, beta-2 glycoprotein, and anti-phosphatidylserine. We have got clinical assays for only these things. Apart from the acquired thrombophilia, the hereditary thrombophilia are very, very important. Protein C deficiency, protein S deficiency, anti-prothrombin 3 deficiency, factor 5 laden. But we do not routinely test for every patient with thrombophilia, inherited thrombophilia, unless the patient's family history is suggestive of thrombophilia. Then and only we test for this hereditary thrombophilia. The clinical things, if patient has got 3 abortions which are less than 10 weeks on ultrasound documentation, and if rest of the uterine, cervical, endocrine causes are ruled out, even the genetic causes which I will come to later, they are ruled out, then we think that there is a possibility of an anti-phospholipid syndrome. Even a pregnancy, single pregnancy more than 10 weeks, if there is a missed pregnancy or a pregnancy loss and all other causes are ruled out, we think that it is because of a thrombophilia, either acquired or hereditary, and in those cases we have to look for those, and the only treatment is blood thinner tablet, blood thinner injections plus minus steroids. We'll come to it in a different video. Again, when we were growing up, we were in our post-graduation, we were taught there is a group of infections which can lead to pregnancy loss. This group of infections is coined by an acronym called as TORCH, and if we add syphilis also to that, it is called as STORCH or TORCHES. TO stands for Toxoplasmosis gondii, R stands for rubella, C stands for CMV, H stands for herpes simplex virus 1 and 2, and S stands for syphilis. We test for these in infections. But like I said, and it is a definite belief that these infections cannot cause recurrent pregnancy loss, while they may cause a single pregnancy loss, but recurrent pregnancy loss may not occur, because most of these infections, once they enter into the body grows IgG against these infections, and it leads to a protective immunity for the further infections in future. But still, most of the doctors, they test for TORCH, IgG and IgM, and they treat accordingly. I find nothing wrong in that, but they do not cause the recurrent pregnancy loss. And they say, according to one study, cytomegalovirus is there in about 50% cases of pregnancy losses. In about 50% cases of pregnancy losses. So now I come to the most important point of this video. What is the most common cause of a recurrent pregnancy loss? Like I said, it is the genetic abnormalities. There are two things. Should we test for the product of conception for genetic abnormalities, and should we test parents for genetic abnormalities? Now, how do we test the products of conception? We do a dilatation and curettage, send the genetic products of conception for a genetic analysis. Now, I have my opinion on this, that most of the product of conception, even if we find some kind of problem, they are isolated chromosomal anomalies, isolated sporadic anomalies, and they don't usually repeat. And even the ESHRE guidelines, European Society of Reproductive Endocrinology, says that genetic products of conception genetic analysis should not be done routinely, and it should be done only for the explanatory purposes or for the research purposes. Ideally, they should be done only when all other factors have been ruled out or they are normal. Second comes is parental karyotype. Do you need to do a parental karyotype again for these genetic anomalies? Now, in couples who have got RPL, like I said, in 70% cases, there is a genetic cause. The parents may have balanced translocation. Which may be a Robertsonian, which may be an unbalanced translocation, it may be an inversion, it may be a deletion, it can be a supernumeric chromosome, whatever. But parents are clinically normal. They may be carrier. There are two types of translocation. There is balanced translocation, in which there is an exchange of the genetic information, but ideally they are, for our practical purposes, normal. Unbalanced translocation, there is unequal exchange of chromosomes. In one may be more, one may be less. They are not clinically normal. When this balanced translocation couples, either in husband or in wife, the sperms or eggs of this couple meet, then the embryos, they produce unbalanced translocations, and those embryos cannot carry to full term. Those embryos may not survive, and that is why to diagnose for further prognostication of this case, to do a couple karyotype, husband and wife karyotype, is very, very important. One more thing. In most of the cases in which there is a chemical pregnancy, in which there is a urine pregnancy test positive, or a beta HCG positive, but that pregnancy is not seen or visible on ultrasound, most of the cases are trisomies. In 60% cases, they are trisomies 16, 22, 13, 21, 15. And these trisomies, they are so severe that they either cannot survive or they have got multiple congenital anomalies in the baby. Trisomies are because of aneuploidy. So like I said, I started my video saying that in about 70 to 80% cases, the causes is unexplained, and out of those unexplained, most of the cases are aneuploidy. Now, suppose I have diagnosed that there is an aneuploidy in a previous pregnancy, the female's age is more, or the husband and wife are having balanced translocation karyotype. Problem is, those parents want child. They have not come to me for explanation, for asking the genetic analysis of their body composition. They want child. They'll come to me and ask, sir, whether we can have our own child. Answer is yes. Now, how do I counsel those patients? There are three approaches. A, they can keep on trying, and the chances that over a period of time they may over cumulative percentage of success is about 65 to 70%, because not all the embryos, not all the pregnancies would be genetically abnormal. One pregnancy may definitely be normal. Over a period of time, if they keep on trying, they will definitely have their child. But if they want a definitive answer, then PGTSR is the answer. What is this PGTSR? See, like I said, if husband has a balanced translocation, or if wife has a balanced translocation, or if both of them have a balanced translocation, then the embryos which are formed via their gametes may not be chromosomally normal. But not all the embryos will be chromosomally abnormal or unbalanced translocation. Few embryos may be normal. How do we find that those embryos may be abnormal? We cannot find those abnormality of those embryos while they are in the body. So we do an IVF for those patients, in vitro fertilization or a test tube baby. We make the embryos and we test the embryos. We do embryonic biopsy. In those day 5, day 6 blastocyst embryos, we take couple of cells. We test them for a genetic analysis. And if those embryos are euploid means embryo is genetically normal, there is no aneuploidy, then we transfer those embryos inside the female's body, and the chances that the embryo may implant, the chances may increase, the chances that a pregnancy would end up in miscarriage would decrease, and the chances that the parents would get a healthy baby would increase. So pre-implantation genetic diagnosis for structural rearrangement is and for pre-implantation genetic diagnosis for aneuploidy is must in this kind of cases. Question is, do we need to go for PGT, SR and PGTA in every case of a recurrent pregnancy loss? Currently, the recommendations do not suggest. But if couple is aging, female age is more, they have history of multiple IVF failures, then we can do, but it is not recommended in all the cases. Suppose my next topic of research is how do I prevent the aneuploidy? How do I prevent the chromosomal abnormalities? How much time do I need for preventing? Suppose patient has a history of recent miscarriage, recent abortion, then I would first and foremost is I would ask that couple to not have pregnancies for at least 3.5 months. Now, why this 90 to 100 days is very, very important for me. A female egg takes about 90 to 110 days to form. So the egg which ovulates today would have started forming about 100 days back. Similar is the case with the sperm. The sperm which ejaculates today would have started forming about 74 to 90 days back in the body. So I need at least 90 days before planning next pregnancy. What would I do in those 90 days? There are three major components of these 90 days. One is a diet, one is lifestyle, and other is medicine supplementation. In diet, I would want at least 40% of caloric restriction to be there. I would want to avoid any kind of refined carbohydrates in form of potatoes, in form of gluten, which is available in wheat and maida. Anything made from maida, all fast foods like pizza, pani puri, burger, bread, pasta, toast, biscuit, cakes, pastries, etc. I would avoid any kind of sugar either in eating or in drinking. And I would want absolutely increased diet in antioxidants. So fresh vegetables, fresh fruits, and fresh salads in form of carrot, in form of beetroot, in form of cucumber, cabbage if patient is not hypothyroid, and at least 40 to 50 minutes of physical activity in form of jogging, dancing, running, swimming, Zumba, aerobics, whatever. But preferably all these activities have to be done differently every day. I would want weight to be in a proper BMI of 21 to 24 before planning to conceive. And supplements. Supplements, vitamin B12, folic acid and vitamin D are very important components of chromosomes, our DNA and RNA. I would like to get a vitamin B12 test done, vitamin D test done. I would like to supplement them in an optimal level. I would also like to supplement antioxidants in form of coenzyme Q, antioxidants in form of L-carnitine, vitamin E, vitamin C, all melatonin, all these antioxidants. These four things, they would make the quality of oocyte and quality of sperms better, and by that logic, the aneuploidy would decrease, and the aneuploidy would decrease, and the chances of normal pregnancy would increase. The chances of miscarriage would decrease. If such pregnancy conceives, then we as obstetricians and even the patients have a tendency to start progesterone in form of injections, tablets, capsules in about dose of 200 to 400 milligrams per day. Cigarette smoking in active or in passive form should be avoided. And like I mentioned, weight loss, weight control is an absolute essential component. Obesity is known to increase the chances of pregnancy loss, is known to increase the chances of early pregnancy loss, is known to increase chances of preterm labor, is known to increase chances of diabetes and hypertension in pregnancy. So weight control is absolutely must before planning a pregnancy. In the conclusion, I would like to say no doctor on this earth can do anything to improve the chances of pregnancy after the pregnancy has occurred. What we need is an inter-pregnancy interval. Between the two pregnancies, we can act on a male and a female. We can improve the quality of sperms and the eggs, and from that, the quality of embryos, and thereby we can have a good pregnancy. Many patients come to me, sir, give some injection, give some tablet, make this pregnancy improve. We can only support that pregnancy with steroids, with low dose aspirin, with heparin, with progesterone injections, with L-arginine, with antioxidant supplements, but we cannot make a bad quality or a bad chromosomal or a bad genetic embryo into a good one. It has to come from the roots. So the important thing is lifestyle, diet, supplements, and a healthy lifestyle for a healthy pregnancy. Please like the video, share the video, and please subscribe to our channel.